Hello, everyone. This is Siddharth Dambar from Chicago Arthritis and Regenerative Medicine. Welcome to our webinar today. So today we are talking about regenerative medicine. So what you will get from this webinar, you'll learn about the best available treatments for arthritis, tendinitis, injuries and back pain that do not require surgery, that are using your own cells, what is legitimate and not legitimate in the field of regenerative medicine, and how to choose the best physicians or clinics for your regenerative medicine procedure as well. And if you have other questions after the webinar or during the webinar, you can always look us up at chicagoarthritis.com. So the big question is, what would you do if your pain was controlled? How would your life improve? What exercise would you restart? And what activities with family and friends would you participate in again? So a bit about who I am. My name is Siddharth Dambar, physician at Chicago Arthritis and Regenerative Medicine, specialist in rheumatology, as well as specialist in image-guided musculoskeletal injections in practice since 2008, participating in regenerative medicine since 2008, and within the Regenix network, which is the largest network of physicians that are collaborating together in regenerative medicine since 2012. So my personal journey into regenerative medicine, essentially my own shoulder. I was a tennis player when I was younger. I learned musculoskeletal ultrasound toward the end of my training, and I discovered that I had some mild injuries in the rotator cuff that got me more interested in diagnostic musculoskeletal ultrasound, which then got me more interested in tendon and ligament injuries, which eventually got me then interested in what are the other treatment options we can actually use for a lot of these common issues that are not really well cared for. So traditional care for things like tendinitis, sprains, arthritis, back pains, essentially are treatment to mask the pain and really just waiting for eventual surgery. And there's so many problems with that, including pain medications don't fix the problem. They do have a lot of side effects, however. They really should only be used for short-term use, not long-term use. Traditional injections, including steroid injections and nerve blocks, they can help with pain temporarily, but they do have side effects, and you need to be aware of those. Surgery, it's appropriate in some cases, but it is higher risk than non-surgical options. In addition, a lot of routine surgeries like arthroscopy can actually accelerate knee arthritis. It can lead to more instability. And treatments like knee arthroscopy, if you already have arthritis, have been shown to not be more effective than just physical therapy. And those of us that are involved in regenerative medicine really feel that 80% of musculoskeletal conditions can avoid surgery. So in searching for better options, we need options where we can avoid side effects and that are low risk, where we can actually improve the cause of the problem, and where we can actually offer long-term improvement. So imagine reducing your pain and getting back to the activities you care about without surgery or pain medications. So regenerative medicine is the process where we utilize your body's own cells to treat arthritis, tendinitis, injuries, and back pain. In the normal healing process, take something as small as a cut on your finger. You have platelets that first infiltrate the area. They first stop the bleeding. They then release growth factors. Those growth factors then stimulate your local stem cells, which then starts a normal healing process, which then starts with inflammation, then layering down more cells, and eventually remodeling of the damaged tissue. That works well in tissue that has good blood supply, but in tissues that have poor blood supply, they tend not to heal very well on their own. That includes tendon, cartilage, disc, labrum, and meniscus. Those tissues can be very initially hardy, but over time, they tend to weaken with recurrent injuries or an injury that's been too significant, and they tend not to heal very well on their own. So regenerative medicine is the process of taking those same cells, your own blood platelets and bone marrow stem cells, and then under image guidance, injecting it into the musculoskeletal tissue that's been damaged in order to help it to recover. So why regenerative medicine? To begin with, we're treating the source of the problem. We're really using the cells that are involved in the normal healing process. We're able to treat not only chronic inflammation, we can treat chronic instability. Those are the two big things that actually drive pain. These are safer than surgery. These are needle-based procedures. They're effective for most musculoskeletal conditions, and really 80% of orthopedic surgery should eventually go the way of regenerative medicine, in the same way that majority of cardiac surgery has now gone to just interventional cardiologists where they're doing needle-based procedures. So how does regenerative medicine work? When you think about an arthritic or damaged tendon or damaged joint, what you have are cells that are no longer functioning well. They're no longer pumping out the right kind of proteins or cells. So regenerative medicine partly can help because we can actually optimize and improve those cells that have been damaged to start functioning better, start putting out the right kind of proteins and enzymes that you see in a healthy joint. Also, by treating the soft tissue structures around the joint, including ligaments, tendons, and other soft tissue structures, we can improve that strength and stability to actually overall improve the overall joint, to improve not only pain long-term, but also function. So we can reduce chronic inflammation, and we can also improve neuromuscular health of the tissue if needed. All that leads to an improved joint, which then leads to less pain, better function, and then overall improved quality of life. So what makes a regenerative medicine expert? I'll be kind of touching on these throughout the rest of this talk, but essentially they need to be a musculoskeletal expert. Really what that means is they should be someone who's focused on your joints and tendons, not someone who is treating high blood pressure or erectile dysfunction in one room and then running over to treat somebody's knee in another room and then bouncing to do something else in the next room. They should be focused. They should be a non-surgical musculoskeletal expert. There is a difference. And for our surgical colleagues, like orthopedic surgery, they're very well trained at surgery. But for things like image-guided injections, they don't necessarily get that same training. And so you really want to be a non-surgical musculoskeletal expert for these kind of procedures. They should use image guidance for all procedures and be an expert on that. I do have colleagues who have been around for a long time and will say that they can inject things without image guidance. To me, that's like trying to find a needle in a haystack. And my opinion is, as long as we've got access to ultrasound and X-ray, let's be more precise and more exact. So image guidance should be used for all of these procedures. They should understand how inflammation helps you heal. Inflammation is not all bad. Inflammation, the setting of an acute injury, is actually helpful in the healing process. If it's too much inflammation or chronic inflammation, that's a problem. So having a really fine understanding of inflammation is important when it comes to regenerative medicine. They should understand the different types of biologic treatments that are used. They should give you a bespoke or personalized treatment approach, as opposed to a one-size-fits-all approach. That's very key, and I'll talk more about that. They should understand the concept of prolotherapy and instability. I'll talk about that in a moment. They should be transparent regarding results of what is realistic and actually be drawing from registry evidence of what is realistic in terms of expectation, not just giving you a gestalt or guessing kind of sense of what can be done. And they should be able to give you a candidacy for treatment, meaning are you a good, fair, poor candidate based on evidence? Again, not just their gut instinct, which is not the way medicine should be practiced. They should follow your results long-term. This is not one where they should just treat you and then just, let you back out. They really should try to keep an eye on you to make sure you're doing okay. And they should be able to guide you through the process. And really that means these are new treatments and they should be able to have a fine understanding of this, answer your questions and guide you through this. So in terms of basics of Regen Med, so is this legal? Yes, absolutely. There are strict guidelines from the FDA, including, are you using your own cells? Are you treating only musculoskeletal tissue? And are you drawing, prepping the cells, and then re-injecting the same day? As long as you're doing that, you are following the guidelines from the FDA. If you're outside of that, and there are physicians who are outside that, then you may be in violation of the FDA's rules. Another common question I hear is, if I'm older, should I use someone else's cells? Simple answer is no, right? Because the evidence is that for most orthopedic conditions, there's good evidence that using your own living cells is effective. There's higher risk when you use somebody else's living cells. In fact, that's not even legal in the United States. In addition, there are a few conditions where if you're older, these treatments can be harder, but for the vast majority of times, there's not an age limit. So hips, there can be an issue if you're over 65 years old, if the arthritis is significant, but the outcomes for everything else that we treat are really not dependent on age. And by outcomes, I really mean in terms of pain relief and functional improvement. What sort of doctor does these treatments? I mentioned this already, but they should be focused on musculoskeletal conditions. They should be focused on non-surgical treatments, and they should really have an understanding of all those other issues so that they're a proper Regen Med expert. So can these treatments help if you already had surgery? Yes, it depends on which surgery, right? If you've had arthroscopy, yes. If you've had back surgery, yes. If you've had joint replacement surgery, we would not be injecting into the joint. So general rules for orthopedic surgeries: try to keep your own anatomy as much as possible. Avoid surgeries that cut out tissue. If you've been recommended surgery, consider getting a second opinion from a Regen Med expert to see if that could be helpful. Understand that your orthopedic surgeon probably is not going to recommend that, right? They don't necessarily have the same experience or expertise in Regen Med, and so it's going to be hard for them to really recommend something that they're not used to using. So I would recommend pursuing a non-surgical opinion, at least, prior to proceeding with surgery. So there are a few real key concepts to understand here, which I'll talk about. Stability is very key in the musculoskeletal system. So in the field of architecture, there's this concept of tensegrity, which means that when you take individual pieces that are weak on their own, if you put them in close approximation and under compression, you get a stronger unit. So in biology and in medicine, that's called biotensegrity. So prolotherapy is the process of injecting your own cells or dextrose into soft tissue supportive structures to help strengthen and stabilize the joint. The key here is to understand that when you have a joint that may be injured, you don't just treat the joint, you treat every level of layer and depth of that unit to make it stronger. When you do that, you get a progressive strengthening over time, which then gives you a longer lasting benefit over time as well. So an example of someone who's had lower back surgery, ×2, still having pain. We ended up treating him initially with his own platelet-rich plasma, treating the ligaments, the set joints, muscles, and epidural space. Key here is treating every single level of what's driving his pain. He had some mild relief originally. We then escalated to using his own bone marrow stem cell treatment cells, and he's now at a 75% improvement. Key here is how to treat each level, and keys here are that if a milder treatment is not enough, there's still options that are stronger and better. Orthobiologic, these are the cells and tissues that we inject into damaged orthopedic tissue. Again, use your own cells, not somebody else's. This uses a normal healing process. So platelets, again, after an injury, they are very key in stimulating your own stem cells, utilizing focal inflammation to then get the body to start healing itself. This is a good first-line treatment. So there's multiple different types of platelet-rich plasma. If your physician sees platelets only as like a one-size-fits-all thing, they're missing out a lot. So the picture on the right, there's platelet-rich plasma with a lot of red blood cells. That's a red one. That is very inflammatory. That'll hurt. And there's platelet-rich plasma on the left, that amber-colored. That is platelet-rich plasma without the red blood cells. Safer for the joint and tendons, as well as less inflammatory. So a higher concentration of platelets is better for joints and tendons. We do vary the concentration based on the issue. For joints, we'll use a very high dose. Tendons, a moderate dose. Other things like ligaments will use a lower dosage. So having that flexibility to adjust your dosage is very key. In my experience, a lot of physicians don't do that, but that's a key part to make these treatments work. So this is an example of a platelet-rich plasma treatment. This is a middle-aged man, cyclist. He was referred to me by his sports medicine physician. He was still having pain, found to have tendinitis. The picture on the right, that is an example of patellar tendinitis. This is the patella of the kneecap. This is normal tendon tissue. This is unhealthy tissue, where you see that, you see the white lines and calcifications. So in his case, we ended up doing platelet-rich plasma. He actually ended up getting 2 treatments, and he was able to get back to his full activity level. He then also had, 3 years later, he presented. Now his other leg was a problem. He was now having hamstring tendinitis. We treated that with platelet-rich plasma. Again, doing great, back to full activity. The picture on the right, again, that's the kneecap, your patella. That's tendon. That's needle, obviously. This is obviously a very zoomed in picture on ultrasound. This is not obviously the kind of needles that we use. This is a zoomed in picture. And really using very fine ultrasound guidance to make sure we're hitting the tissue that needs to be treated and not tissue that doesn't need to be treated. Other keys here are sometimes repetitive treatments are needed, and when they are, people do really well. And also that if we need to treat another issue, people do well with that also. So the next orthobiologic to be aware of are using your own blood or your own body's bone marrow stem cells. Stem cells are the main cell that drives tissue repair and recovery after an injury. Again, use your own cells, not somebody else's. There's risks associated when you use somebody else's. your body senses that as foreign and it can react to that. Bone marrow-derived stem cells are legal in the United States. Fat stem cells are not legal. You can use fat or adipose for other treatments or other structural support. That is still legal in the US. And so we do use it for things like rotator cuff injuries, just because it adds a little bit more connective tissue there. But we don't really use it primarily as a stem cell treatment. Amniotic or umbilical cord cells, that used to be something you probably heard a lot about in this country. You probably don't hear too much about it now. And the reason why is because there's no living cells in that. And there were physicians who were using this and billing insurance inappropriately. And so the FDA and the FTC have started to crack down on this. IV stem cells, not something you see in this country, really no proven benefit for orthopedic conditions. I do have patients that are going elsewhere in the world to get these kind of treatments. Very hard to guide them because there's very little evidence whether that works or not. So in terms of outcomes, a couple things to keep in mind. Number one is, common question I get is, hey, I've got advanced arthritis. Can these treatments still help? And the simple answer is, yeah, I can. That's based on the evidence that we have, that even if you have advanced arthritis in areas such as the knee or the back, you can still do well. Hips are an exception. More advanced hip arthritis is harder to treat. Can we improve your images? So if you've got advanced arthritis, I can't get that to look like what it was 20 years ago. If you have a tendon tear, we can get that to look close to normal, especially if the tear is still relatively mild or moderate. If you have a ligament tear, same thing. I'll show you some examples of that. If you have swelling in an arthritic joint, absolutely. If you've got a condition called avascular necrosis, where the bone is starting to die, we can improve that as well, as long as you're catching that at the right stage. So can we treat bone-on-bone arthritis? Simple answer is yes. Again, understand arthritis is a biologic condition. Arthritis is not just when your doctor does an x-ray and puts it up and says, hey, look, you've got bone-on-bone arthritis. That's not what arthritis is. Arthritis is a progressive process where you have soft tissue injuries, like in the ligaments, which then leads to instability, which then leads to stress on the bone and the cartilage and other structures, which then leads to swelling and inflammation, and then eventually pain. That term bone on bone really misses a lot of the biologic nature of things. And so the great example of that is someone who has knee arthritis and has been told they have bone on bone knee arthritis, and yet they still have really full range of motion. So if your range of motion is still close to being intact, and even if you have advanced arthritis, good outcomes are still very possible. Caveats to that, number one is advanced hip osteoarthritis, very challenging. We usually recommend that for hip replacement surgery. In addition, your expectations, let's say for treating your knees, shoulder, back, other areas like that, are really about pain and functional improvement. Again, I cannot reverse time and get you back to where you were 20 years ago. And reality is there's nothing that can do that. But if your goals are, can you get 70% or better pain relief, functional improvement, better quality of life, those are things we can still help out with. So can we treat tendon and ligament tears? So we've got some great pictures of this. So this is a knee ACL case. This is, so if you have a partial thickness tear, definitely. Full thickness tear, as long as the tissue is still closely approximated, we can treat that. Here's a great example of this. If it's fully torn where, they're flapping in the wind, tendon ends or ligament ends, that needs surgery. Even that though, if you've had surgery, having your own bone marrow stem cells re-injected in is actually helpful in terms of preventing repeat tears. So this is an example of a 28-year-old man. He's a butcher. This is a regular guy playing volleyball, tore his ACL. I saw him really pretty soon after he'd injured his ACL, which is important in his ability to recover. We ended up using his own bone marrow stem cells, and 3 months later, he had no pain. We started dynamic exercise, and I'll show you what his images look like in a moment, his MRI images. So the picture on the right is a picture of his treatment. So that's his kneecap. That's the thigh bone. That's the shin bone. That's the needle. Again, this is zoomed in. What's lighting up here is his ACL. So how do we know we're injecting the right tissue? Well, we see that we're injecting the right tissue. We're not just guessing. We're not just hoping. We're very exact. And so what's amazing here is not only did he have a great clinical outcome in terms of pain relief and functional improvement, but this is his MRI. So this is pre-treatment MRI on the left, kneecap, thigh bone, shin bone. Here's the ACL. Bottom of the ACL, you can see, as you go further up, it starts getting disorganized and you don't really see it. The radiologist has essentially read this as possibly a full thickness tear of the ACL. Very disorganized, very injured. Picture on the right. Again, kneecap, thigh bone, shin bone. Here's the ACL now. Now you see an image that is very linear, very intact, and very clear-cut. So he's had not only a great clinical result in terms of pain relief and getting back to activity, he's had a great-looking MRI result as well. It's another interesting MRI result. This is a gentleman in his mid to late 50s. He's a contractor, chronic shoulder pain. We end up using his own bone marrow stem cells. 3 months out, doing great in terms of activity, no longer having pain, back to working. But here's his ultrasound, really interesting. So picture on the left is the ultrasound before treatment. That's the rotator cuff. That's the bone. This little gap here, black gap here, that is his tear. Same thing down here. That's a full thickness tear. So picture on the right is post-treatment. That's tendon, that's bone. And now you see tissue that's basically filled in and healed. Great result in terms of clinical improvement. Great result in terms of improvement in his imaging improvement as well. Okay, great. So interventional orthopedics. Interventional orthopedics. So this is the process where we use image guidance to treat orthopedic injuries. Why do we need image guidance? A couple of reasons. Number one, we need to be precise. So this image on the left, you see the following. So that's the rotator cuff tendon. That's the bone. This is the needle. It's a very small tear right there. So that kind of small tear, understand this is zoomed in. This size is closer to 1 by 1 millimeters. Very, very small. You can't inject that blindly. All right. You can only inject that with very fine-tuned ultrasound guidance. This is an example of even more than that. So it's an X-ray example of injecting into the shoulder and the labrum. So this is the humerus, that's the glenoid, and this is the needle. So number one, how do we know we're in the joint? Well, we have a little bit of contrast in the joint to confirm that. When you inject cells, you can't just be close to the target tissue, you have to be exact. And if you're not exact, you're not going to get the right effect. So in his case, we're very exact here, but also this little triangular structure that lights up here, that's his labrum, right? So that, you cannot do that blindly at all. To inject that carefully and precisely, you really need image guidance. So not only do you need it for being very specific in your location, but you also need image guidance because there's certain structures you really can't inject otherwise. I showed these pictures before. The picture on the left is the patellar tendon injection with his own platelets. Again, if you want to inject the precise tissue that's been damaged, that's how you have to do it. Picture on the right is injecting the ACL. I showed this before as well. And again, if you want to inject tissues like this that are very hard to inject, very hard to even see, you really need X-ray guidance for this kind of injection. This is a case study of a gentleman that has ankle avascular necrosis. Avascular necrosis is a condition where you have swelling in the bone that eventually leads to death in the bone, eventually damage in the cartilage. So he's a 41-year-old cook or chef. He's on his feet for 12, 13 hours per day. Obviously, he's developed some pain from that. Picture on the left is before his treatment. So this is the ankle joint. He's got some fluid in there. This white signal here is avascular necrosis. The bone is essentially dying. Luckily, the cartilage hasn't been damaged yet, but if we don't do something about it, it will. So we end up treating him with his own stem cells 3 months later. Pain is great. And where you had that signal, it's the picture on the right. You see that prior white signal is now gone. So he's had a complete resolution of his avascular necrosis, doing great. He's a few years out and continues to do well. Regenerative medicine treatments offer safe and effective solutions for your pain. Let me catch up on some questions here. So, okay, some good questions here. How long after treatment can you start back with physical therapy? Right. So, realistically, after treatment, what we tell patients is you'll have more inflammation, which means discomfort and swelling for the first 3 days, stiffness for the first week or so. You're okay to do activity as tolerated. So I think if you're trying to utilize physical therapy, I'm okay with you working with physical therapy probably after a couple of days. I'd probably take it easy for a couple of days. But realistically, even if you work with them the first day after treatment, the same day after treatment, they would just have to go lighter compared to what they normally do. Range of motion exercises are fine. Light strength exercises are fine. But I would generally recommend probably give it a few days rest. From a exercise, kind of regular exercise standpoint, I think you give it a week's rest, kind of restart at a low level, like maybe 30, 50% of your normal level a week later, and then you slowly increase it as each week goes on and you're feeling better. Somebody else asked, what does the fat do when mixed with PRP? It's an interesting question. So I think it does a couple things. The first is that you're adding connective tissue. Fat has a lot of extra just connective tissue stuff. And what's nice about that is if you have, let's say, a tendon or ligament tear, is that sometimes you don't just want your own blood platelets or stem cells. Sometimes you want that little extra supportive scaffolding in there. I think that's very helpful in those kind of conditions. There is some evidence that using adipose or fat injected into knees, if it's been sort of microfragmented, where you just kind of mix it down, you kind of get rid of some of that structural support, that can actually help with knee arthritis as well. So I personally don't routinely use fat with PRP a lot. I do have some colleagues that do. I do use it for tendon and ligament issues, though. I hope that answers that question. Okay, good. So other common questions. Is this too good to be true? So, there's data from Philip Hernigue, who's been doing this since the 1990s. He's a French orthopedic surgeon. He has case series where he has a patient, same patient, using bone marrow stem cells on one knee and knee replacement surgery on the other knee. And he finds very similar results, except less side effects in the stem cell treatment group. He has outcome data for shoulders and knees that go out over 20 years. The Regenerative Network has data that goes back since 2005, registry data following patients for a long time. I have colleagues who probably 10 years ago were saying, hey, there's no evidence for these treatments. They don't recommend it. They don't trust it. Those same colleagues now are telling their patients it might work. They're not sure. They'll offer it to their patients, but they're not sure how well it's going to work. So things are rapidly developing. I have personal experience since 2008. And what I tell colleagues or patients is that is the field new? Not really. Like there's practitioners that have been doing this for 20 plus years now. For me, we're at like 15 years now. So it's not new. It's rapidly developing for sure, but it's not new. There are definitely right and wrong ways to do this. A lot of that you learn just with study, but most of it you learn with experience, right? And so for folks who are relatively new at this, yeah, it probably feels like it's brand new, the field. But for those of us that have been doing this for a while, not really. It's really not new. Your expectations as a patient should be grounded in reality, evidence-based medicine, what has really been proven and what is safe and appropriate, and what really can we do? So how long do results last? Again, Regenerative data, I said 10 plus years, but they have data that goes back to 2005. Philip Hernigue from France has data that goes over 20 years now. However, what I tell patients is think conservatively. If you have a chronic condition, let's say you've had back pain for 20 plus years, you've had a lot of different treatments before you've had, let's say, platelet-rich plasma for the back. For a chronic condition, expect that a repeat treatment at some point will probably be helpful. So what would be an example? So let's say we have a patient that's had bone marrow stem cell treatment for their knee. They're doing really well. They're still continuing to do well. Let's say they're 2, 3, 5 years out. They've got a little bit of regression, right? But they're still doing better. Probably a platelet treatment would be helpful at that point. The nice thing with these treatments is if you look at a steroid injection, you get an immediate benefit and then it comes right back down after weeks to months. With these treatments, there's a slow progressive increase. And at some point, that trend will flatten out. For something like platelets, that'll be about 3 months. For something like bone marrow stem cells, that'll be 6 to 9 months or so. And generally, you'll hang out at this higher level for some time. If you do get a little bit of a dip, or if we end up repeating treatment because you're not quite at your goal, you're now starting at this higher baseline. You're not starting all the way back down at square one. You're starting at this higher baseline, and now you're stair-stepping to a higher level than that. So the best way to maintain results after treatment: improve your biomechanics, do the right exercises, take the appropriate supplements that help with pain and inflammation, eat well, exercise. Repeat treatment, again, is additive to initial treatment if needed. Cost, common question. Again, this is not routinely covered by insurance. The exceptions are if you work for a self-insured company. For example, most large companies are self-insured, actually. If you do, go to regenexcorporate.com and ask them if they can add these procedures as a benefit plan to their company's insurance plan. That is possible. Self-insured companies can do that. There's a couple thousand companies that now are covering this throughout the country. We're seeing more and more folks who have this as a covered benefit. However, if your insurance does not cover it, here are some expected cost estimates throughout the US that you'll see for prolotherapy, platelet-rich plasma, and stem cell treatment. These are very realistic expectations. Keys to determine value. Number one, is your physician and clinic a regenerative medicine expert? Are you receiving a real stem cell treatment, or maybe something that's a mislabel like an amniotic or umbilical cord treatment? And again, keep in mind that these are in-office procedures. You don't need to go to the hospital or surgery center where you start incurring more facility fees and things of that nature. So this was my list of what makes a regenerative medicine expert. You have to be a musculoskeletal expert. They should be a non-surgical MSK expert. They should know how to use image guidance for all procedures. They should understand how to use inflammation to help you heal. They need to understand the different types of biologic treatments that are used, not just use a one-size-fits-all treatment approach. They should use a personalized treatment approach for you. They should understand stability in prolotherapy. A lot of my colleagues don't, which is surprising. They should be transparent regarding your results, potential results, and your candidacy for treatment. If they can't give you that, they're probably not experienced in this. They should follow your results long-term with you, and they should guide you through the process. So really, what does it take to be a regen med expert? It's really everything. It's all the details. It's not just taking a simple course or willing to try something. It's really doing this properly. Just a little bit more about how we do things here at Chicago Arthritis and Regenerative Medicine. We are focused on non-surgical treatment for your arthritis, tendinitis, injuries, and back pain. We start with a big picture evaluation approach. What's going on from inflammation, stability, asymmetry, neuromuscular issues. Try to correct with low-risk interventions. Most patients that we're seeing have already tried those kind of interventions. If not working, then considering regenerative medicine treatments, using the best options that are appropriate for you, plan that's specifically tailored to your issues, and using cells or delivering those cells with the highest level of image guidance. So if interested in getting evaluated, in the chat section, you'll see that there's 3 different ways you can do that. You can call us directly, you can email us directly, or you can even just schedule directly onto my schedule. So that was a lot. I realize that. If anyone has any remaining questions, please put them into the chat or question section. If not, then I will end the webinar relatively soon. And if you're interested in watching this at a later time, you will get an email from us for a link where you can watch it again. If you have friends or family that want to check it out as well, by all means, please forward that link to them as well. And I appreciate everyone's time today. If there's no other questions, thank you, everyone. I hope everyone has a good day. And if we can help out in the future, please let us know. But I hope everyone does. Here's a question that came through. Someone asking about cost. It really depends on what's being treated. Someone's asking about treating one finger versus treating a hip. It depends. You probably don't need the same sort of treatment for a finger that you do as a hip. Hips generally will end up using bone marrow, while a finger, we're generally using probably more platelets as a first-line treatment. And so costs will be probably different just based on that. But fingers can be treated. I see a lot of hand patients just as a rheumatologist. I get referred a lot of patients who've got hand issues. So those can certainly be treated as well. Okay, wonderful. Well, thank you everyone for your time. Until we connect again, hope everyone has a good day and live well. Bye-bye.